Hello and welcome to another Hope to Sleep webinar. My name is Tim Brown. I'm the Vice Chairman of the charity and I'm going to be the moderator for this evening's event. We've got a really interesting topic for this webinar. We're going to be looking at the important and often underappreciated link between sleep apnea and various eye conditions, so including Floppy Eyelid Syndrome, cataracts and glaucoma. We're going to be hearing about how untreated sleep apnea can trigger and even heighten the risk of some eye conditions, and also how eye care professionals are actually really well positioned to identify undiagnosed sleep apnea during eye examinations. We've got two really prominent speakers for you on this topic this evening. So firstly, we have Kath, founder and CEO of Hope to Sleep charity, who's going to share her recent experience with cataract surgery as someone with sleep apnea, and how she managed her CPAP mask usage after the surgery. So thanks for sharing your experience with us tonight, Kath. And secondly, we have Mr. Sid Goel, who is a consultant ophthalmic surgeon at the Eye Correction Centre in the UK. And he's also the clinical lead for their East Division. Mr. Goel is going to talk about the clinical links between sleep apnea and eye conditions, and also touch on the importance of avoiding dry eye disease, especially with CPAP and ventilator usage. So thanks for your time today, Mr. Goel. There will be the opportunity to ask questions to the speakers at the end, so please use the chat function on your screen and we'll do our very best to get through them after the presentations. So without further ado, I'd like to pass over to Kath, who's going to share her experience of eye surgery as someone with sleep apnea. Over to you, Kath.
Welcome to, it's been a while since we've done a webinar. We've got two more lined up actually. But tonight it's about the eye, and I thank Mr. Goel as well for coming along to join us on this webinar to educate us on the links between sleep apnea and eye health. Because we know how important our breathing is, and most of us have got that fixed that we can keep breathing during the night constantly now we're on treatment, but obviously our eyes are very precious as well. And we already know how many medical conditions untreated sleep apnea is linked to. And like the apneas, the pressure on the heart, but the oxygen desaturations, that affects all of our bodies, including our eyes. But I'm not going to take away from Mr. Goel because he's going to tell us about that. But that's the purpose of this webinar. I am aware, as I've been through, this webinar is very popular, and I know there's even been a lot of people registered so they can get the link as soon as they can, who aren't even in the country at the moment or are on holiday or whatever, which obviously we always do. But I am also so aware that a lot of you sent the link to your own eye clinicians, and there has quite a lot of them joined us tonight, which is absolutely great because, we know that dentists and we know that ENT consultants, can often spot the signs through of sleep apnea through routine appointments with them. But not a lot of eye clinicians know that, and hopefully they will after tonight. So, about sleep apnea, we've already done webinars on that. Most of you already know what sleep apnea is because you either suffer from it or you're treating patients. But there are also, the eye clinicians that have joined us may not know. So obviously sleep apnea is, about not breathing. Apnea is Greek for without breath, and during sleep we do stop breathing. But I don't want to, talk a lot about that tonight because we have lots and lots of information on the webinar. Natalie will put you a link to our own website, What is Sleep Apnea, where you can read about that. But basically, with obstructive, it's usually in snorers, although it is possible to have sleep apnea without snoring. But the obstructive sleep apnea is the most common one. 8 million sufferers in the UK, and I would say 80% undiagnosed. So all these different specialities that can help people get diagnosed and save lives is absolutely fabulous. So Natalie will pop that if she hasn't already. But we've also got a previous webinar. We've got, for those of you who know Dom Jolly, he is what is he, our patient, what's the word, Tim? Thank you, patron. Patron of the charity. He joined us on a webinar, told us about his own story, but also you know, we spoke about sleep apnea. Samantha, who couldn't join us tonight, our chairman, because she's on holiday, she also talks about the clinical side. So if you want to have a look, Natalie, not now, obviously, because that's a webinar for another day, but if you want to have a look, Natalie's going to put the link in the chat for you. If you want to copy and paste that, I mean, copy and save that link, and then if you are interested, you're not sure if you've got sleep apnea or you just want to know more about it, there's a whole webinar on that. So to me, before I was diagnosed with my own obstructive sleep apnea, severe I might add, I suffered for many, many years with floppy eyelid syndrome. Now, my own optician was aware of this annoying condition, but she didn't realise, and neither did I, this was before I was diagnosed, of the possible link between floppy eyelid syndrome and obstructive sleep apnea. Despite some studies that I found out later, as you always do, hindsight's good, stating that 90 to 100% of people with floppy eyelid syndrome have obstructive sleep apnea. And of course, we will all know this. So, coincidentally, and it was literally 2 days ago, so I copied this, I came across a post from a patient who's been diagnosed with sleep apnea in a private group. So I'm not sharing the name, but I will share what he said in his opening. He said, "So I was diagnosed with severe sleep apnea in September 2022 with an AHI of 68. So he was stopping breathing 68 times an hour. Interestingly, my optometrist alerted me to the possibility of having sleep apnea, as I had none of the classic symptoms at the time, apart from tiredness in the afternoon. Listen to your medical professionals, folks," he says. "Floppy eyelid syndrome is a symptom, and luckily my optometrist knew this." And I thought that was quite amazing that I came across this 2 days ago. So that guy, she's probably saved his life with an AHI of 68, because that really is severe. So my own personal experience when I was first put on CPAP, which was a long, long time ago, was that my floppy eyelid syndrome vastly improved. And my optician was amazed, and she became very interested. I actually took her the article in and the research, and she was just amazed and said she was going to look for the link herself in patients, because obviously she'd just come across floppy eyelid syndrome a lot. Now, I wouldn't say it's gone away completely, and it can certainly come back if I'm stressed or overtired or run down, but it's definitely heaps better than it was. And another thing that happened after I was diagnosed, Mr. Goel might know the reason for this, is that my eyesight improved initially, so much so that my optician advised me to just use glasses for reading. I am going back about 20 years. And even then, I only needed them in certain lighting. And I could read in bed with my CPAP mask on, using a Kindle just with a slightly raised font. However, age. We can't stop here, the aging process. So several years down the line, I did actually have to revert back to glasses. But then, unbeknown to me, cataracts were also developing in both eyes. And Mr. Goel will be addressing the reason for this later. I'm wondering, which you might mention later, Mr. Goel, that was it to do with better oxygen while my eyes improved? That's my own theory, but you'll know more. So I had my first cataract done on my lazy eye by the NHS with amazing results, considering it was my lazy eye. I remember messaging Tim because Tim is the chairman of our charity, but what you don't know is no, you're not the chairman. You're the vice chair and trustee. Is actually just by coincidence, Tim actually works for a company called Retinal, who actually make lenses. So I was always messaging him when I was doing this surgery, shall I, shan't I, dare I, Tim, asking his advice. So I did, like I say, I did have very good results. And I remember telling you, Tim, I can actually read through my lazy eye. And you were really pleased for me. But for my second eye, I did need to go private. Because what I didn't realise is, as good as the NHS is, for us, they are only able to supply monofocal lens, and which actually was fine for my lazy eye because it was just a bonus. I could see through it after all these years, but I did need the best outcome for my good eye. Well, good without the cataract, I mean. So this is when I first met Mr. Goel at his eye correction clinic in Hull, because he suggested I needed EDF lens, which would give me a better range, not just that single range on my lazy eye, to give me an extended range of focus for that second cataract surgery. And I will say, looked after me very well. He even gave me an oxygen bar during the surgery. I don't know whether he was frightened I flaked out because of my sleep apnea, but I had extra oxygen. It was very nice. And he was trying to also talk to me about holidays to distract me. And he was asking me the favourite place to go for holidays. And I spent the whole operation trying to remember the name of the country. And then right at the end of the surgery, I remembered Cyprus. Yeah. So anyway, my surgery went very well. Mind you, I will say that it's a good job I did go to Mr. Goel for this second surgery, because with his own routine checks, he did discover that, unfortunately, I'd developed a macular edema cyst behind the eye where I'd had the first cataract surgery. And I needed treatment for that, because otherwise it would have gone unnoticed before that damage was done, because it wasn't due to be checked again. So I'm very grateful to that. And I'm pleased to say that on our last visit anyway, a month ago, he was able to give me the good news that he did not need to put the dreaded needle in my eye that I was dreading, because he'd managed to cure it. So the cyst is gone, and please stay away. So, like I said, my experience with Mr. Goel has been top class. And if flipping floaters hadn't decided to visit me a few months ago after my surgery, I wouldn't even be using these glasses, because initially I didn't even need glasses at all. But these floaters are just a bit annoying, but we're hoping they'll settle down, because these things can happen anyway after surgery, I think. But one thing, like I say, I did have to go private for my other one, but I'm saving a fortune in glasses, because I no longer need my designer glasses that I used to pay an earth for. These glasses, I think, were about $8.99 from Boots, because I don't need prescription glasses now. All I literally need is a +1 range. And I only really need them because when I'm reading, because I'm just reading my notes, so I don't go over my 15 minutes. So, yeah, so I'm really, really pleased with the outcome. I hope that these floaters go and do one, because they're just annoying, really. That little annoyance, but it's just my look that. But Anyway, so before I finish, I want to just briefly touch on cataract surgery for those who use CPAP or non-invasive ventilation masks. Now, the reason I say it is because there's confusing advice out there given to cataract patients post-surgery. When I had my first one done through the NHS with Spa Medica, they said to me that I only needed to use the patch for one night. Now, I didn't believe that because I know that we put a mask on, there's risks of mask leaks, air can go into the mouth. So I use my own judgment, and I used that for a couple of weeks. And we got talking about it in the group, and other people were saying, how long should I? Because they say, you know, only a couple of nights. So the advice out there, you look on, even on different NHS boards, where even on different NHS clinics, and they'll say, use the eyesight patch overnight for between 1, or some will say 2 to 3, or some will say 5 nights. Well, I asked Mr. Goel's advice after my second surgery, and he said, use it at night with CPAP at least 10 nights to cut down the risk of dry eye during the healing process. And funnily enough, people in our group, as I told them that, because some have had the surgery since then, and you know, that's exactly what they did or intend to do. So if you had cataract surgery yourself, and maybe other eye surgeries, I don't know, that need that patch at night. I was hoping to bring a patch with me, but when I looked in the packet, they'd all gone. So I don't have one with me. So I just want to demonstrate, those of you who've had cataract surgery or treat patients with it, you'll know that it goes over there, just the patch, sort of on a slant, and it comes about down there, I would say, down there. So if we look it down there, if I happen to be using this simplest mask, I don't just mean the simplest, I mean any mask like this. If you imagine that eye patch is there, can you see the problem, right? You're going to get leaks from the mask because of the eye patch. So I would suggest not using a mask like that because it's going to interfere. The mask I use is the Dreamwear full face, and there are other similar masks as well, as you all know. There's the Evora, there's the F30 range. So can you see that that is literally, I can't do it on here. Yeah, like this, and there's loads and loads of room for that eye patch. So I just want, people to consider that, because sometimes they don't think ahead. They have the surgery, they, oh no, what am I going to do? Because they're frightened of not using the eye patch, and they're also frightened of not having, using the CPAP. And it's obviously highly suggested that after surgery, any surgery, but for the eyes as well, we need good oxygen to heal us. So, it's just something I thought I'd throw in there for preparation. And that's me finished. Thank you.
Thanks, Kath. You always get honesty from you, that's for sure. Honestly, Kath, of your own experience. So thank you. Next, we're going to move over to Mr. Goel, who's going to be talking to us a bit about the clinical link between sleep apnea and eye conditions. So over to you.
Thank you, Kath, for nicely summarizing all my slides. There's not a lot of work for me to do.
Sorry. I tried my best not to.
Welcome, everyone. Thank you for sharing your evening, or if you're not in the UK, whatever time of the day you're in, and I hope you're having a good summer. I've got a lot of slides, actually, because I wasn't sure how long you wanted me to speak for, but I can carry on for as long as you want, and I'll stop whenever you tell me to. I'll be very honest with you. Thank you for welcoming me into the sleep support team. Me and my team have actually learned a lot from you, Kath. I don't profess to be an expert in this, but I think my knowledge is growing rapidly thanks to working with you, because obviously I know about the different aspects that affect patients in terms of the science element of how the disease or the condition, I should call it, can affect the eye in terms of the challenges both before or after any potential interventions, or even without the need for any intervention, dry eyes, for example, in milder cases with regards to their eyes. But it's very interesting to hear it from your point of view about how, the concerns and the worries you take away. So I'm going to try and present what I have learned by interacting with people like yourself. By no means this is comprehensive or an unlimited resource of knowledge, and I'm sure I'll know more as I interact with more of you in the future. But here goes as to a little summary of how this condition can affect patients who suffer from this condition and their eyes. So a little bit about me. Thank you for your introduction, Kath. I am a consultant ophthalmologist. I work with my organization, which is called the Eye Correction Center, which I'm a founder director of. It's essentially based in the north of England, and we have a west side division and an east side division, and I lead the east side division. And these are my specialist interests in cataract surgery, corneal and anterior segment surgery, which also includes dry eye disease.
Do you share your screen? So.
Yeah.
Oh, I'm so sorry. I
was just messaging you, Tim, to say, am I missing it? Yeah.
So as you can see, we've been out of the Zoom world for a long time now. Most of my presentations currently are face-to-face. So it's a little bit, I'm reminiscing on my COVID days, where it was all, when I was talking to people by looking into a screen. Fine, it does block off part of my screen, but okay, that's Zoom for you. Okay, I specialize in cataract surgery, corneal and anterior segment surgery, and which includes the spectrum of dry eye conditions and also oculoplastics. We established Eye Correction Center way back in 2008. This is for the benefit of those who are not local to where I'm based, because we do have units in the west side as well, Manchester, Liverpool, North Wales. We're a team of 6 consultants at the moment, but growing. We work with a number of opticians, orthoptists, clinical assistants, nurse specialists, photographers, and a large admin team who help us to support you guys, our patients, in terms of us delivering what we like to believe, patient-centered and patient-focused, high-quality care. And we take great pride in how you feel about what we can do for you by keeping on top of all, cutting-edge services. We're learning all the time. We never feel that we are above learning. And thanks to Kath and the Hope to Sleep team, we've learned a lot about this condition too. And we're trying to update our clinics, our resources, our facilities, constantly investing in equipment all the time. And in fact, we just had a meeting a few days ago about investing more into dry eye treatments, particularly with the view of helping people who suffer with significant dry eyes, as in sleep apnea sufferers. And as I said, we have a number of locations. If you feel we can help you in any way, please do reach out. We're very proud of the feedback we've received from patients like Kath, who've been part of our family, if you like. We are honest, just like you are, Kath. And, if you'll recall from our conversations, I've never minced words. I've laid things out fairly plainly, what you can expect, pros, cons, risks, benefits. And I believe that's what's helped us to get to number 2 in the country as far as Trustpilot ratings are concerned. So thank you to our patients for putting your faith in us and for also rating us very highly. Now, as I mentioned, I have my own specialty services, which is cornea anterior segment, vision correction work, and oculoplastics, and also cataract surgery. But we do work with other specialists who support, advanced treatments and investigations in glaucoma, retina, strabismus, and of course, general ophthalmic services. Since 2008, my team and myself have seen well over 40,000 patient contacts. So we feel quite proud of the steps we have taken to get to where we are today. So Kath has already gone through the slide, but very quickly, I'll just point out the things which I'm sure you already know, because all of this will have some bearing and relevance to my next slides. So as you know, sleep apnea syndrome, the most common one being obstructive sleep apnea, where the walls of the throat narrow during sleep, interrupting normal breathing, is characterized by stop-start breathing during sleep. And the symptoms are usually due to either decreased oxygen or increased carbon dioxide building up in the bloodstream, causing gasping, choking, significant snoring, waking up. As a result, tiredness, concentration problems, apologies for the spelling mistake there, mood swings, headaches, and it's commonly associated, but not always, to patients who have issues with weight control It's more common in males, but menopausal females can also be affected. It's usually in the older age groups of 40 years or more. It can be more in patients who have large necks, or patients who are on sedatives, medication, narrow airways due to tonsils, adenoids, problems with the tongue, small jaw, nasal congestion. Basically, anything that obstructs the airway can predispose. Things that suppress the breathing efficiency, such as alcohol, smoking, can also be contributory, and it is known to run in families. And we know the management includes lifestyle changes, trying to lose weight, and so on, stopping smoking, of course. But we also have, as Kath mentioned, opportunities to use positive pressure breathing devices like the CPAP device. So my apologies, because of the way Zoom is constructed, the bottom part of the screen disappears for me. Let me see if I can move it to one side. No. Okay. Anyway. Yeah. My slides won't progress. Okay, here we are. So the parts of the eyes that can get affected. I know we concentrate a lot on dry eyes, which of course is a prominent problem, but I've come to learn that it can affect any part of your eye. And this is an anatomical cross-section which shows that basically every layer of the eye can be affected, right from the eyelids. Can you see my mouse moving around out of interest, or is it my?
Yes, you can. Yes.
You can. Okay, so it can affect the eyelids, which I'll show you. It can affect the way your eyes focus. It can affect the tears, which layers the front surface of the eye. It can affect the cornea, the clear dome in front of the eye. It can affect the inside of the eye by way of raising pressure, glaucoma. It can affect the lens, can cause cataracts. It can affect the retina. I'll show you examples of retinal problems. And it can affect the optic nerve. That pretty much has not spared a single layer in the eye. So let's walk ourselves through how this can happen. Now, dry eyes. I know you're very keen on knowing more about dry eyes, but I have to be careful not to spend the whole presentation on this, because I could easily do that. So I'm going to try and give you a little summary. Now, effectively, patients who have clinically significant dry eyes come in to see us like this: redness, soreness, grittiness, itchiness, blurred vision, sensitivity to light. Interestingly, often they have symptoms of watering in certain conditions. And that is because there are two elements of tears on your eye surface: the basal tears, which is what you should have all the time to keep the eye surface moist, and the tears that are produced in response to an irritation, or reflex tearing. So when you have a low level of basal tears, your eyes respond by periodic reflex tearing, which is what leads to watering. And all of these things can lead to problems in patients who wear contact lenses. It can make them intolerant, which of course is not a nice thing, because they're looking for relief for their visual functions by use of contact lenses. Now, what does the dry eyes actually do? Two things happen to your tears. There's a decrease in volume of tears, or there's an alteration in the quality. And the common clinical tests that we use to determine whether you have one or both in various combinations, in terms of volume, we look at the height of the tear film on your lid margin, and that's called the tear meniscus. And the height of that is called the tear prism height. Typically, we want to see more than 0.2, and it can be reduced in dry eye sufferers. But even if you have normal volume, the quality of the tear can be disrupted. And here is an example of where we put some fluorescent dye on the eye surface and shine a light at it. Now, what you should see is a uniform coating on the eye surface. But clearly, you can see all these big black holes, which suggest that the tear film is quality is not very good. There's a number of other things we can do. We can assess how well tears are being produced at the rate of production by something called a Schirmer's test, which is where we put a little filter paper and we see how quickly the wetting spreads down the paper. We can assess to see how concentrated your tears are by using what's called a tear lab device. It measures the tear film osmolarity. There are options like using meibomography, which is using infrared light to look at how many glands you have. A dropout or an alteration in the morphology of the gland suggests that you have some disease process on. And now we have options of opportunities to do blood tests, serology, immunology, to look for associated immune conditions which can make this problem worse. So these are the common dry eye symptoms that patients present with. Now, we learned, especially during COVID time, that masks play a significant role in the worsening of evaporative dry eyes. So dry eyes can be decreased production or increased evaporation. Now, when you have wind blow. If I sat in front of you and steadily blew wind across, or put a fan on in front of you, or just blew some air across your face, your eyes are going to dry out because evaporation is going to increase. So similarly, when you have a mask applied to your face and there's a little a wisp of air going across your eyes, that's going to increase evaporation. Now, obviously, these masks are to prevent the spread of COVID, but CPAP masks are meant to be airtight. But if there is any leak whatsoever, you can expect that symptoms of dry eyes can be exacerbated. So that's something for you to be aware of. Now, dry eyes can also be a part of other syndromic associations in sleep apnea sufferers. Now, Kath has already done a lot of explanation, given us a full explanation on floppy eyelids, but this is an example of a fairly severe case of floppy eyelids. And in floppy eyelids, as Kath has mentioned, has a significant association. Studies showing somewhere between 80 to 100% in different studies, where patients with sleep apnea are known to have associated floppy eyelid syndrome. Here, there's excessive elastin deposit in the tissues of the eyelids, and this in turn makes the eyelid very stretchy, and the stretchiness causes a few things. The first is it makes the eyelids not blink or move properly, which means that there's a higher risk of exposure of the eye surface, and the eyelid does not shut properly. This in turn can increase the rate of evaporation from the eye and increase dryness. The other thing is that when you've got a big volume under the eyelids, the tears that are produced are not sufficient to coat the eye surface and that big space, and the tear volume effectively becomes deficient. And this in turn also leads to drying. Subsequently, you get a mucus production because the eye is now in a constant irritated state. And this excess mucus production can harbor bacteria, lead on to infections. And these infections will then cascade more inflammation, which will also add to the dry eye disease process. So you can see it's not simply musk and air that goes across your eye that can predispose to evaporative dry eyes, but other conditions that are associated that can also contribute. Now, floppy eyelids can cause more problems. For example, because the eyelids have lost their tone and tension, it can fall away, as in this example on the left. So that's the same floppy eyelid that I showed in the previous slide, and here the lower lids are completely falling away. So as you can imagine, the upper lid doesn't meet the lower lid, the eye is exposed, and there's risk of increased dry eyes, and in fact, that increases the risk of infections too. The opposite can happen. The lid can fall inwards, and this risks scratching of the eye surface, which in turn can be quite potentially risk damaging vision if this delicate structure of the cornea underneath can get damaged. Chronic inflammation relating to floppy lids or dry eyes or both, because of a chronic inflammatory process can lead on to secondary infections, and that's called blepharitis. Blepharitis is inflammation of the eyelids, which can be infected. And in severe cases, glands in the eyelids can get blocked and infected, causing styes and hordeolums, all of which can be very uncomfortable and debilitating. And these can be recurrent in patients because you have about 100 glands in the upper lid and about 50 glands in the lower lid. So this can keep coming over and over and over if the condition is not managed. As I said before, if the eyelids are turning in or the eyelids don't shut very well, the surface of the eye, the cornea, is not protected, and the epithelial covering, it's like the skin of the cornea, can break away. And that's called an epithelial abrasion. This can be extremely painful, and it can be recurrent. You may wake up every morning with severe discomfort, pain, and blurred vision. And a lot of patients can be debilitated by this. And if it goes on and on and on for months and months and months, you can end up with quite nasty scarring on the eye surface. Now, I will say I have no financial interest to the extent that I'm not getting paid for this presentation, and I thank the numerous journal publications from whom I've borrowed some of these slides in order to make this talk effective. So some of these are, borrowed from other presentations that are available. So you can see how varying levels of scarring can be quite damaging to vision. And we have ways of undertaking scans like this slide here, which shows the hot spots. The red spots are the hot spots where there's excessive scarring. We can monitor where you are in the scarring and disease process, and whether it's remaining the same, getting better, or getting worse with time. So this is a very helpful tool for us to know what your situation is over a period of time. Now, the condition that we worry about, particularly in patients who rub their eyes, and there have been, fortunately, it's not hugely prevalent in the same vein as, say, dry eye disease or floppy lids. But in patients who rub their eyes, and we know that floppy lid sufferers tend to be eye rubbers too, and patients who have significant irritable eyes, such as in dry eye sufferers, there is an increased tendency to rub eyes. You can actually distort the cornea or the anterior surface of the eye, where instead of being round and spherical, it becomes conical. And this distorted eye can be severely damaging to vision, to the extent where you might not even be able to see very well with glasses, and you may need rigid contact lenses. And of course, as you can imagine, if your eye surface is already very sensitive due to dry eyes or floppy lids, these kind of contact lenses may not be very well tolerated. And now you're left with a nasty situation where your vision is down and you're unable to find a suitable solution. So this is an example of a keratoconus where the patient's eye has become very conical. And again, on our scans, we're able to see these hot spots where the cornea is protruding forward. And it helps us to diagnose and offer treatment options for patients who suffer from this. So eye rubbing is not a good thing. And there are studies that have now absolutely unequivocally proven that eye rubbing can cause keratoconus. Now, glaucoma is also something that we do see in sleep apnea sufferers. Now, what is glaucoma? First of all, let me try and explain that. So glaucoma is effectively a condition where the eye is not empty. It's filled with some jelly-like, and also part of it is more watery fluid. The front part is more watery, the back part is more jelly-like. And this creates a certain amount of pressure within the eye, which is called the intraocular pressure. So the structures within your eyes have to be able to withstand this pressure. And in particular, in glaucoma, we are concerned with how the optic nerve, this nerve at the back, which carries the signals from your retina to your brain, from the light signals that are put on the retina, how that optic nerve withstands the pressure within the eye. In glaucoma, the ability of the optic nerve to withstand that pressure has gone down, and you can see here what happens. The central part of the optic nerve, which is basically it's nerve fibers that are the myelin sheath, begins to expand at the consequence of the actual nerve fibers that carry the signals. So when your cup or the central part, the white part in the middle, becomes wider, it means there are less viable nerve cells in the nerve, and that is effectively damage to the optic nerve. So in glaucoma, the optic nerve cupping gets significantly widened, implying damage to the optic nerve. Now, in the past, it was considered that it was purely a function of pressure, i.e., the higher the pressure, the more the damage. But there's been lots of evidence now to suggest that it's a combination of the balance between the pressure within the eye and the perfusion or the blood supply to the optic nerve. So the blood supply is a combination, again, of how much blood is provided, but also how much oxygen that blood is able to carry with it. Now you can see where I'm going with this. If in situations where, even if the pressure was normal, even if the perfusion was normal, that i.e. the amount of blood being carried was normal, if the oxygen carried by that blood was reduced, the optic nerve is at risk, i.e. you're at risk of glaucoma. Now, what happens in glaucoma? Well, the first thing that happens is the peripheral visual field suffers. And you can see here, through various stages of glaucoma, the patient's losing peripheral visual field. And we have tests to document how much field has been damaged. And we can also see, if we start treatment, what happens to that field. Does it arrest, or is it continuing to progress due to other ongoing factors? So it's very important for patients with sleep apnea to be aware that the hypoxia that they suffer from when they are in apneic episodes increases the risk of glaucoma. Now, if in those patients, for whatever reason, the pressure in the eye is raised, it compounds the problem. So you have to be aware of that. So when you go and see the optician, make sure that they check your eye pressures. Now, there are different types of glaucoma, open angle glaucoma and narrow angle glaucoma. I don't want to make this too confusing for you all. Both types can affect sleep apnea sufferers. In open angle glaucoma, these red arrows here indicate the pathway of flow of the fluid within your eye. It comes from some structures very close to the lens and goes around the iris and is drained out from a structure which is called the angle. In open angle, this angle is nice and wide and open. Now, why would you get glaucoma in open angle status? Well, one of the common reasons why patients can get glaucoma is if for whatever reason they've been on steroids for large periods of time, particularly drop steroids, not so much tablet steroids. The drop steroids may in turn be used for conditions where the ocular surface or the eyelids are very inflamed. So for example, patients who suffer from allergic eye disease, significant dry eyes, they may be put on drop steroids, and that in turn risks the formation of glaucoma, right? Now, narrow angle glaucoma is where these structures within the eye crowd that angle, and as you can see here, and therefore there's no pathway for the red fluid to flow. This can also affect sleep apnea sufferers, and there are various reasons this can happen. The first is if a cataract develops, it pushes the structures forward. Sleep apnea sufferers are more at risk of developing cataract if they've been on steroid treatments for bronchial or lung management. And also, there are some theories that there's increased circulation of adrenaline in sleep apnea sufferers, which in turn risks the iris dilating more. The iris is this gray structure here, which is the brown or the gray of the eye. And when that dilates, it crowds up the angle and increases the risk of narrow angle glaucoma. And the worst case of narrow angle glaucoma can get what is called as an angle closure attack. And when that happens, the vision can get very severely affected with pain and redness and congestion in the eye. And this can be more in patients who are naturally long-sighted. So if you have a plus prescription, then be aware that if you're a sleep apnea sufferer, then you are at risk of narrow angle glaucoma. As I said, glaucoma causes visual field changes, and we can document that using formal visual field assessment. We can also assess objectively the state of your optic nerve by conducting scans like this, which tell us how bad that cup is. It takes pictures, it maps those pictures, and then we can do a progression analysis over time to see if the numbers are remaining stable or getting worse. This is an example of how much the rim has been damaged relative to what would be a normal person. The rim is this healthy portion around the cup. If that gets thinner, it means the glaucoma is worse. So you can see here in this particular example, there's a couple of red areas, some yellow areas. That's telling us relative to a normal person for that age and for that sex, this eye is showing evidence of damage. So this is called an OCT scan, which we can do to map the back of your eyes. To give you an example, what you would expect if you were being checked for glaucoma. Now, as Kath has said, she's had her cataracts done, and cataracts can affect people for a number of reasons. Commonest one being age-related. It is more commonly seen in sleep apnea sufferers. There's good evidence of that now. Postulations are potentially the higher likelihood of use of steroids in these patients for lung management in order to optimize their breathing status. Now, obviously, if you get a cataract, it's a bit like having a dirty, smudgy window. Your vision gets blurred. Fortunately, these days, surgery is very effective to cure the cataract. The difficulty, of course, is what we consider to be fairly routine and straightforward may not be as simple for a sleep apnea sufferer. So, for instance, we require a patient to lay flat on their back for about 20 minutes during the surgery. Now, that can be a bit challenging. So we have things that we can do, such as we increase your oxygenation, but as Kath mentioned, by providing you a good flow of oxygen under your eye cover. Because we have to isolate the area at the time of surgery, so we have to cover the eye, and of course that covers the mouth. So we make sure there's an increased supply of oxygen under there. We give you a good amount of acclimatization time so that you're not rushing through these things and getting short of breath. We are able to reposition our table in a way that your neck is not hyperextended or bent, and give you a more neutral profile to what you're used to. Our tables bend at multiple different levels so that we're able to keep you quite comfortable during the surgery. And of course, in experienced hands, the surgery goes through fairly quickly, so you're not on the table for too long. These are the things we can do to try and help. As Kath mentioned, sorry, again, a part of my slide is missing, but never mind. As Kath mentioned, we do take advised precautions with use of your CPAP mask in the postoperative period, especially masks that have the wider triangular configuration mask that could potentially sit against the eyeball, because the last thing we want is direct pressure on your eyeball in the recovery period, especially because a number of sleep apnea patients have to sleep on their side. We know that sleeping on the back is more challenging. And of course, as Kath mentioned, you want to be very careful about having any air leaks across your eye for a number of reasons. One of them being it can make the dryness worse, but the other one being there's a higher risk of infection because, as you know, the mouth carries a lot of bacteria in it. Now, sleep apnea sufferers can also suffer from optic nerve problems. There are two main conditions that we see. One is called anterior ischemic optic neuropathy, AION. This is essentially hypoperfusion or hypoxemia of your optic nerve. And as I said to you earlier, the optic nerve carries all the retinal signals to the brain for your sight. So when you get hypoxia and that leads to damage to the optic nerve, typically what we see, you won't see this of course, is that the nerve looks swollen and pale at the back of the eye. And when we do a visual field test, you get what like a pattern like this, which is called an altitudinal field defect. It's split, like a midline split, but either at the top or at the bottom. You can also get raised intracranial pressure, or it's well known that increased carbon dioxide, decreased oxygen can cause raised pressure within the brain, which in turn can lead to, which is why patients with sleep apnea often suffer with headaches. It's secondary to the raised intracranial tension. That can lead to swelling of the optic nerve, which is called papilloedema. It's, again, like ischemic optic neuropathy, the margins of the disc go fuzzy, but unlike ischemic optic neuropathy, when we look at your eyes, there is more pink or more congestion. So here there's pallor or paleness, here there's more pink or congestion. And in papilloedema, we see the blood vessels are more tortuous, more dilated. They look more normal in ischemic optic neuropathy. And you lose pulsations of the blood vessels on the eye nerve. And just describing to you things that we as the ophthalmologist or the eye specialist would see in discerning one condition from the other. This is more hypoxia directly to the nerve, and this is secondary effects of raised intracranial pressure. Unlike in ischemic optic neuropathy, you don't get an altitudinal defect, but you get a widening of the blind spot in papilloedema. You can also get retinal problems. Kath's retinal problem was not directly related to the sleep apnea. It's a secondary to inflammation from surgery that she had. But things that are directly related to sleep apnea are vein occlusions. Because you get raised pressure in the brain, similarly, the brain cerebrospinal fluid is connected to the fluid around the optic nerve. And that raised pressure can cause sluggish venous circulation. And when that happens, you can get a condition called a central retinal vein occlusion or branch vein occlusion. You can get lots of hemorrhages in the eyes, exudation within the eyes, which in turn can cause swelling at the macula. All of these can damage vision, sometimes very, very severely. This can cause glaucoma, but also the glaucoma that can be associated with sleep apnea can cause vein occlusion or can make this situation worse. This situation can also be predisposed by diabetes or blood pressure, which is not uncommonly seen in sleep apnea sufferers who are on the overweight side. And of course, if you've got diabetes, you can get diabetic retinopathy, which is also a vascular disease of the retina. This not the same as vein occlusion. More vein occlusion, you get swollen disc, lots of hemorrhages, big dilated veins. Here, you get more of these dot and blot hemorrhages and exudates. So diabetic retinopathy looks a little bit different, but one can be connected with the other. Central serous retinopathy is where the central part of the most sensitive part of the retina can get elevated with the fluid collection. This is usually due to oxidative hypooxidation and damage to the layer of cells which pumps fluid out of the retina. So you can get collections of fluid into the retina. So as you can see, there's a whole host of different things. It's not just dry eyes that can affect patients. Let me just check the time. How do you manage these? I mean, I could spend another hour now talking about that, but I'll give you a brief summary. Obviously, treat the cause, notwithstanding the things you can do to help with your sleep apnea, which is to increase oxygenation, lose weight, not rub your eyes. There are a number of other things you can do to help the problem that is specifically affecting in terms of the eye condition. So if you've got dry eyes or eyelid problems, that can be managed with a variety of drops, whether it's lubricants or anti-inflammatory drops, steroids, as I mentioned in some cases, being aware that the steroids themselves carry risk factors like secondary glaucoma, or you can have non-steroidal anti-inflammatory drops that can be helpful too. Sometimes we have to use serum that has been drawn from the patient's blood to help supplement the tears. We may have to use tablets to help, such as you could have antibiotics or vitamin supplements to help with patients who suffer from eyelid inflammation or infections. Heat mask therapy is very helpful for patients who've got certain types of inflammatory eyelid disease called posterior blepharitis. What it does is it helps to liquefy the fatty collections and allow for easier expression. Lid wipes to take away crusts and bacterial collections on the eyelashes can be very helpful. Lippy flow devices, compression devices, which actually apply heat and squeeze the meibomian glands and help the expression of the collected secretions can be helpful. Intense pulse light therapy can help to reduce blood supply in the periocular area, and therefore that in turn reduces inflammatory drivers on the eyelid margin. In patients who suffer from floppy lids, of course, we can try all the conservative measures as mentioned just now, like lubricants and avoidance of eye rubbing and so on. But in some cases, we have to do surgeries to help shorten the eyelids if they're suffering significant problems. Ocular surface disease, as I said, entropion, interning of the eyelashes, ectropion, failure of the eyelids to shut, severe dry eyes, recurrent erosion. Again, a number of things can be done to treat these effects. Drops, lubricants, antibiotics can help settle the eyes in a number of cases. In some occasions, which patients I have dealt with, have had to put contact lenses on to work like a bandage, sometimes for several weeks. And I have a few patients who are pretty much on lifelong contact lenses because at the moment you take it off, the erosion problems come back. So we can sometimes do that. There have been occasions where there are patients who are suffering so much with debilitating pain that I have to give them a period of keeping their eyelid shut using botulinum toxin to work like a natural bandage, because use of artificial bandage, synthetic bandages may be unsafe in their eyes. So this is another option. Then patients who've developed keratoconus as a result of rubbing their eyes, we have options like obviously settling the ocular surface disease first using drops or tablets or other measures, but then we can cross-link their corneas. Cross-linking is a way of exposing the cornea, which is bending into a cone, to high doses of ultraviolet light, like in this example here, which stiffens the cornea artificially and arrests the progression of keratoconus. Now, as I said, these patients can be sometimes left with problems with vision. Contact lenses don't work very well, glasses don't work very well, and then we have to do surgical steps to help address their vision problems. And these are examples of surgery we have to do. Sometimes we have to do very invasive surgery like corneal transplantation, but these days we have other options before getting to the transplantation stage, like putting rings, artificial ring segments to reshape or rebend the cornea to allow for better vision, or sometimes putting specially designed contact lenses inside the eye. So the point of this slide is to show you that there's a huge range of things that we can do to try and optimize the situation. So this has gone back to glaucoma now, sorry, okay. So in glaucoma, if you do develop glaucoma and you're unfortunate enough, we can try and bring the pressure down in your eyes. That can be done with drops or tablets. Sometimes we have the narrow angle glaucoma. We can use a laser beam, as in this bottom example here, to make a little hole in the brown or the gray of the eye, which is called an iridotomy, and that restores the flow of fluid within the eye. But sometimes you have to do more formal filtering surgery. Fortunately, we don't see a lot of patients getting to this point these days, but it is an option available to us. Cataracts. If we did develop a cataract, this is what we would do. We make a tiny keyhole incision, put a fine probe in, take the natural lens out, and that leaves an empty space. After we've cleaned up all the little fibers that are in the eye, we put a nice little tiny foldable or rollable lens that goes into the eye. Now, as Kath said, these days we have lots of sophisticated options where if you are unfortunate enough to need your cataract removed, there are sophisticated things we can do to actually help you with your focus function, such that we may actually get rid of your glasses. Now, not everybody needs that. Some people don't wear glasses to begin with, others are not bothered. But for those who are in that unfortunate situation that you are needing to have the surgery done, then that is an option that can be evaluated for you. Unfortunately, optic nerve problems and retinal problems don't have an easy fix in terms of drops, tablets, or surgeries. And it's more a case of medical management, options like losing weight, increasing oxygenation, managing blood pressure, diabetes, and trying to keep a close watch on steroids that are necessary for other medical conditions in terms of how they may have an effect on the eye. So I hope I've not overloaded you. with information. And that brings me to the end of my presentation. Thank you very much for your time and patience.
That was fantastic. Thank you. So educational. I think it's also amazing how there can be such a link between different conditions, whether it's eye and sleep or other areas of health as well. But I think what's a key takeaway for me is your last few slides, which showed actually there's so many management options for all these conditions. So if anyone is suffering, there is management out there for the conditions. We've got a couple of minutes left before we wrap up. So a few questions there. Kath, there's two you've marked as wanting to answer live. So,
Yeah, do you want me to read them out, do you mean, Tim?
yes, please.
Yeah, okay. So Justine's asking, she was diagnosed with sleep apnea in 2010 and in 2015 developed bilateral 6-nerve palsy. There was never a cause found, and it was treated with prisms, and it eventually resolved in around 4 months. Because there was never that cause found, she's now wondering, could that have been due to sleep apnea?
Yes. Idiopathic intracranial hypertension and papilloedema are known to be associated with 6-nerve palsy.
Ah, I knew that, but I didn't know that was connected. That's interesting, Justine. Yeah. That's.
So, I mean, it may not be, but there is. Unfortunately, Justin, there is a very clear association between the two.
Yeah. So that's hindsight again, Justine.
Correct. So management of your papilloedema is obvious. I'm assuming that you had papilloedema. Obviously, Justin is not available to answer the question, but I would assume that Justin had papilloedema, and that led on to this. And so management of the papilloedema is key. Managing the hypoxia, managing the hypercapnia, and in some cases of severe problems, like in Justin's case, they may even have to use a shunt. There are tablets like Diamox that you can use to bring the pressure down, and in some cases, surgical shunts are necessary.
That's interesting, Justine, because that is certainly, you know, that you need to keep using your therapy, don't you? You know,
but more importantly, make sure that you're seen by a specialist to make sure that it's not getting worse, because what you don't want is papilloedema persisting over a long period of time.
No, thank you for that. And there was another one about, what about the link between uveitis?
So there hasn't been any established link, but I would not go so far as to say no, but as it stands, because we are still learning about this. I'll be very honest with you, there's a lot to be learned about, more about this particular condition. And we know that hypoxia can cause all kinds of problems to the human body, right? And we know that one of the things that hypoxia does is it causes inflammation. So uveitis is basically inflammation within the eye. Now, that being said, I'm not a uveitis specialist, but I've worked in uveitis teams. There hasn't been an established link that I can speak to you about. But I wouldn't like to say that it's impossible, right?
That is true, because new links come up all the time. And talking about inflammation, Sue Goel talks about we know that already there's a link between sleep apnea and rheumatoid arthritis. And she goes on to say that in America, they're researching eye drops to dissolve cataracts.
This is a conversation that has been going on since I was a trainee, which sadly was in 1990.
Yeah.
I may look young, thank you, but that's Zoom cameras doing their magic.
Well, it's still interesting if it's on the horizon. So
there's lots of things being researched.
Yeah. So I'm not, let's put it this way, I'm not holding my breath, no pun intended.
No. And Julia, she says as well, we're talking about all these conditions described as associated with sleep apnea. Well, I'm just making sure I'm thinking the way you're thinking, Julia, associated with untreated sleep apnea, i.e. not using CPAP. When we're talking about the low oxygen, we will be talking really about untreated sleep apnea. Would you agree, Mr. Goel?
Yes and no. So curing hypoxia will address a number of factors,
Mm.
right? It will reduce the risk of glaucoma in so far as hypoxia is a contributory factor.
Yeah.
It will not reduce the risk of glaucoma insofar as use of steroids, for example, for management of dry eye disease is a contributory factor. It will not reduce the risk of cataract insofar as the risk of use of steroids is a contributory factor, or associated diabetes is a contributory factor.
No,
But-
that's the
yeah.
thing. There's other there are other risk factors, but the
Correct,
other thing
correct.
what I would this is only my own opinion, is that when we get treated for sleep apnea, we can't reverse everything. We can reverse a lot of the damage, and we can stop it in its tracks of a lot of the link, not just eyes. I'm talking about a lot of the cardiovascular and all the other links.
So if nothing else, you're going to reduce the risk of progressive damage.
As long as we're using our
That is contributed to by hypoxia and in sleep apnea, all of these, hypoxia is one of the big contributors, right?
Yeah. It's just amazing how many. I mean, there's two other questions I'll link together here: double vision and blurritis.
Blepharitis. Let me open the chat. Maybe I can have a read. Where are you? I would assume that blurritis is actually blepharitis.
Right.
So blepharitis is inflammation of the eyelid margin, which I covered in my slides, which can be often associated with dry eye disease or floppy lid syndrome. As you know, floppy lids can improve. Dry eyes can, improve because floppy lids have improved, and also, how you manage the airflow across your face can help with improving on dry eyes. So a number of factors. I suppose the answer is there are elements within the conditions that are reversible.
Yeah.
But not everything is reversible.
No, that's right. Because like you said, there's, although you're treating your sleep apnea, so you've stopped that in your tracks, you're still dealing with diabetes. And if that isn't managed as well as it could be, that still leaves you open to, other links, doesn't it? It's other risk. Yeah.
Well, there's a question from Bella saying, is there a danger for me as I've had corneal transplants and use of sleep apnea machine?
So it would depend on what the corneal transplants are for. If the corneal transplant is for a progressive condition like keratoconus, for example, and Bella is on the younger side, which means that there's a higher risk of progression, the direct pressure of the mask on the cornea can increase the risk to the cornea. And of course, the cornea, a transplanted tissue has a lifespan of about 10 to 20 years. So you want to minimize any direct pressure on the transplanted tissue as well. So I would recommend, like Kath has shown at the beginning or towards the middle of her talk, mask options which do not put direct pressure on the eye.
Yeah. And most of us would prefer them now instead of the big full face ones. Obviously it's hard for us to find the right mask, but the ones that are going up here are more likely to leak in the eye than the newer modern type, which is like the Dreamwear or F30, that masks are improving, and that's going to improve on the eye. We've got Martin Bucknell actually. He is a sleep clinician, and he's actually thanking you there. He says how interesting it is, and he's certainly going to add eye conditions into his own teaching sessions on sleep apnea for other healthcare professionals, because it's often overlooked, and also encourage research projects in the area. And we'd be very interested in helping with research, Martin, as well at the charity as the PPIs. Because I'm, very passionate myself, and especially as the newer links, if you have a look, Martin, they're quite new, are the links between cataracts and sleep apnea. I only discovered them when I had my own cataracts. So thanks for that encouraging message.
There's a question from Emma saying that, are there any eye mask that be recommended for use for CPAP. It's something it's the other way around. It's the mask that needs to be changed as opposed to the eye mask. It doesn't be so many ways you can cut up. Right? Yeah.
Correct.
And what's this about punctal plugs?
Yes, they are a very useful tool. As I said, there's so many things that we can do. It's difficult to cover everything. But that's
What are they? What are they for those who don't know?
So that's a little bit more invasive. So that's basically, so if you think of your eye surface as a sink, there's a tap, which is a gland that's producing your tears, and then there's a drain on the inner corners that draining the tears out. And then, of course, there's evaporation. So the tap has to be on and producing enough water to give you a good fill halfway down the sink, and the drain has to be open enough so that it's a constant flow in and a flow out, and the evaporation is a minor element in getting rid of some of the tears. Now, if you're not producing enough tears and you're losing water to evaporation, you want to slow down the drainage. And to slow down the drainage, you can physically put a little plug into the outflow system, and that's called a punctum plug. It's definitely in the armamentarium of things that we do, but it comes into the second stage of a little bit more invasive therapy, if you like.
Yeah,
it's not things that commonly occur in sort of non-clinical environments. They have to be done in a clinic, whereas all the other therapies I showed you can be done in non-clinical environments.
Have you got a question there, Tim?
Just more of a comment from Dorothy saying her floppy lids are getting worse despite using BiPAP.
Are you having leaks? Oh, you can't answer me, can you, Dorothy? Mask leaks from your BiPAP. Is a lot higher pressure than CPAP usually, and it's a lot harder for us all. I'm on one myself to get the seal to make sure it's not leaking. So I would definitely be looking at that. But I'll leave you to answer. Do you think the actual mask, the type of, if you're wearing a big mask, I'm wondering that under the eyes, could that cause it? The floppy eyelids.
Can you frame that again for me?
Yeah, she says the floppy eyelids are getting worse using a BiPAP machine. If someone's using a mask like this, would that make it worse?
So I would guess no. Right. Because for your floppy eyelids to get worse, there generally is a combination of, so sleep apnea sufferers tend to have an association with floppy lids, right? It doesn't necessarily, usually it's in patients who are on the overweight side, but I have seen plenty of patients who are not on the overweight spectrum or moderately or mildly on the overweight spectrum have quite significant floppy lids.
My floppy lids were bad.
Right?
And so, I got that overweight.
So
I need to lose some though.
But what is well known that losing weight helps. It is well known. It is also well known. So in the order of management of floppy lid syndrome, before we offer surgery, for example, we say lose weight, get sleep therapy, then come for surgery. So what does that imply? Losing weight helps reduce the deposition of lipids and elastin in the structural tissues of the eyelids. That's one way. And that can actually make the situation better when you lose some weight, right? The second is sleeping on your back, because it is well known that when you sleep on the side, there is some pressure on the eye, continuous, prolonged, dragging pressure, and that can cause a degree of stretchiness. So for instance, we have seen patients who are right-handed have more floppy lids on the right side, or more floppiness. People who sleep on the right side have more floppiness on the right side, and vice versa, of course. So unless your mask is physically dragging on the eyelid, I would say no. But if it is, then yes.
Yeah. You've got
so it's not so much the mask. It's not so much the mask itself, but more the traction that the mask is applying on the eyelid. That I would ask how much of a role do you think that has to play?
You see, I had a discussion with you at one of my appointments, and I know you would love us all to sleep on our back, but the sleep consultants would actually want us to sleep on our sides.
Well, yes,
so
because
one's better for the sleep apnea, one's better for the eyes.
the uvula, the connective tissue in the uvula and the throat, it collapses more in sleep apnea sufferers, right? Especially OSA sufferers. So when you sleep on the side, at least the uvula is out of the way. And therefore, that stridor, because of that, the flap at the back of your throat falling and covering up your breathing apparatus is out of the way. But on the other hand, again, with CPAP and with weight loss, it has been shown that actually sleeping on your back becomes easier. On the other hand, sleeping on the side has the problems that I've described to you. I don't know how many, even keratoconus. So patients who develop keratoconus, if you're unlucky to develop keratoconus, will be worse on the side that you sleep on.
Yeah.
That side vision will be more damaged compared to the other side. So there's a number of negatives that are, it's that finding that balance between getting your oxygenation sorted by sleeping on one side versus the fallout of side sleeping, if you like, you know?
Yeah, yeah. We've got a little discrepancy here because Rod's saying when Emma was asking about eye mask, I took it that she was referring to mask to stop airflow over the eyes. So we've got a few different things. We've got the CPAP mask. Then we've got the eye patch, we should call it, which is what you need after cataract surgery and perhaps, for all I know, some other surgeries. And then we've got people who are.
I think sorry to interrupt you. For simplicity, I would suggest maybe call it an eye patch or an eye shield.
Yeah.
And versus a mask. Otherwise, the word mask can get.
I know, it comes up so many times because it's looking at what Rod and Emma said. I think she was talking about eye sleep masks. Because a lot of our members in our groups are telling each other what sleep masks they've found, which I actually always say, try to, rather than trying to disguise the leaks, try to get a mask that isn't causing the leaks in the first place, or to get your mask fitted.
Correct.
If people do have to resort to a sleep mask, this is my own question as well, which is good that it's as tied in with Emma and Rod's, is that are sleep masks, these cloth masks, really helpful to us? Or can they damage things? Because I often thought,
cloth masks, did you say?
Yeah, you know, the cloth or satin or silk or, you know, all those sleep masks.
Like you might wear on an aeroplane, maybe.
Ah, okay. Sorry, even I've gotten confused.
Yeah, you see, there's that many different masks.
So you're referring to the kind of stuff you would wear on an aeroplane to keep the
leaks
light
away
out.
with the CPAP. Yeah, but it's not for that. They're using them so that if the air's going near their eyes, they're opening the sleep mask. Those cheap things, well, they're not always cheap.
So straight away, I'll tell you.
Yeah, that's what I want.
Whether you're an OSA sufferer or a sleep apnea sufferer or a non-sufferer, please don't wear a mask when you sleep at night.
Yeah, that's always been my gut feeling.
Yeah, because for a number of reasons. A, it has direct prolonged pressure on your eyeballs, which is not good for anyone's eye. It increases the intraocular pressure, decreases the optic nerve perfusion, and we know optic nerve perfusion falls the most at night. That is why patients get vein occlusion attacks, usually first thing in the morning when they wake up. If you've got tendency for keratoconus, you've got direct pressure on the eyeball. If you've got a weak inner layer of the eye, what we call corneal guttata, you're going to make that worse. If you've got a tendency to have allergic eye disease, you're accumulating secretions under that mask all night long, which in turn can get bacterial infections. Tears are collecting in that mask and soaking up into that mask through the night. It can abrade directly against the eye surface and cause I think I've given you enough reasons why you should not wear a
I,
mask.
you know,
Don't wear a mask.
Yeah.
I'm really pleased you said that, because people, all of you in our group, you will notice Kath goes quiet when you ask for a recommendation, because my gut feeling has always been you shouldn't really wear something cloth.
You're
over
much
your
better
eyes.
off getting something that has a good seal that doesn't leak air.
Yeah, treat the cause,
Yeah.
not the symptom.
Correct.
Yeah. So now we've got a challenge there. Oh, so Justin's just put, I've been in my eye masks. Justin, I started wearing some eye masks when I moved to the new house because too much light was coming into the bedroom. Something happened with my eyes, they were even more blurred. So I actually got blackout curtains, and definitely that was a better option.
Absolutely.
Yeah,
Let
but
the windows suffer the masks, not your eyes.
yeah, it's you know, I mean, people will say that they're fine, but I personally don't, you know, ever join those conversations. I always go quiet because there are those eye masks out there, and if they're that bad, you'd think, how come they're allowed to sell them? So, you know, but I just prefer to sit on the fence on that, on those questions in our own group.
That's a very clear and strong way to end the webinar, which is overrun by nearly 20 minutes, which I think is a good thing, actually.
Yeah.
The discussion that's happened. So
yeah, and you'll be pleased to know that you've actually answered all the questions, which is very unusual. And that is really good, and you know, really thank you for coming along.